Hello and welcome to the Clinical Update Podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Dawn Liz Powell, medical editor at MIMS Learning, and I'm delighted to be speaking today with Jane DeVille-Almond. Jane is an obesity specialist nurse consultant and is president of the British Obesity Society. She'll be talking to me about the importance of supporting people to maintain good nutrition while losing weight, particularly if they are taking weight loss drugs. Welcome to the podcast, Jane.
Hello, and thanks for inviting me.
Okay, so what do we mean by obesity?
The World Health Organization defines obesity as abnormal and excessive fat accumulation that may impair your health. And although BMIs aren't foolproof, I think it's important to recognise that they've been used for quite a long time as an indication of the possibilities of you developing a health risk if you have a BMI greater than 30. And we know from all the studies that the higher your BMI gets, the more likely you are, and it's not always the case, but the more likely you are to develop either type 2 diabetes or heart disease, high cholesterol. So although BMI isn't foolproof, it's really a good way of discovering whether someone might be unhealthy. More importantly, I think, is body mass index and waist measurement, because obviously people with a larger waist, it's an indication that you've got visceral fat. And also, like, obesity contributes to biological changes that are outside lifestyle issues, and they can impact on your leptin and your ghrelin. And these control your hunger hormones and feeling of fullness. Ghrelin and leptin are what the new GLP-1 drug works on. So ghrelin stimulates appetite. So when ghrelin's released in your body, you feel hungry. So obviously you eat more. And it also promotes fat storage. So it stores your fat in your body. It's a way of protecting us from starving to death. It's like thousands of years of your body learning how to stop you starving. It affects how your glucose and your carbohydrates get absorbed in your body. But if ghrelin isn't working properly, your sugar will go into your bloodstream and your insulin doesn't work as well, and so it doesn't get rid of it. And that's when obviously things like type 2 diabetes occurs. And leptin, they produce fat cells that actually regulate your appetite. So they send messages to your brain to say, we've got enough fat stored for today for all the energy you're going to need, so you don't need any more to eat. So it stops people overeating. So those two are incredibly important things to think about. And fat tissue itself can become active. I like to think of it as like a monster inside your body, and it can actively release hormones and inflammatory chemicals that can make you feel unwell. So obviously the more fat you've got in your body that's over and above what you require, then the more likely you are to not feel brilliant.
So obviously you're talking about someone who is obese, who might feel unwell. They come into the GP practice and you can see that patient looks big. And then there are people who you think, you don't look well. I mean, that's part of the fact that they are overweight. And also, is it because the diet themselves might not be nutritionally very good?
Exactly. And it's difficult really, because when someone comes in about something totally different to their weight, it's quite hard to bring up obesity because people feel like you're judging them on how they look. But as a healthcare professional, we need to give our patients all the information they'll require. And basically, if you're Asian and you have a body mass index over 23.5 to 24.9, you're deemed to be overweight. And if you're Caucasian, it's 25 to 30. And if you're Asian, it's a BMI of over 25. You're deemed to be obese. And for Caucasians, it's a BMI over 30. And although people might be healthy currently and might look healthy, as one gets older and your body starts to not work quite as effectively as it does when you're young, then that's when problems often start. So we're looking to protect people, not just for the moment, but for the future. And one of the other things I think it's worth mentioning is your body has a set body weight. So if, for example, I get up to 14 stone, my body will remember that weight and it will always try and get me to go back up to 14 stone, because anything below that, it thinks that my body's gone into starvation mode. So it becomes incredibly difficult once people get bigger for them to lose weight.
So, okay, just to recap, so somebody comes in to the GP practice, perhaps you can have a conversation about their weight. Could it be that they come in, they say, oh, my diet's fine? Like, how is it sometimes that they could come in and you think, well, actually, what you're eating is a healthy diet, and it might be that their diet is they're eating a bit too many bigger portions?
Exactly. And it's interesting to note that people, even though they're big, they can often be malnourished. And actually, there's a terminology for that. And it's referred to as a double burden of malnutrition. And it's when someone has a high calorie diet, but the nutritional value is practically nil. And obviously, you know, they might be eating high sugar, high fat diets, a lot of takeaways, and a lot of ultra processed foods. And these obviously don't contain all the nutrients, vitamins, and minerals that our body requires. So even though they're big, they might be nutritionally not particularly healthy. And so I think it's important to explain to them the necessity to eat nutritionally valuable food, proteins, lean meats, porridge, beans, bran, rice, all of those to keep your body functioning healthily. It's hard because people get into set patterns with food. You probably do it. Everybody does it. We tend to eat the same foods over and over again. We think we don't like certain foods because we don't eat them often enough.
So yeah, so you've got somebody who's perhaps eating a nutritionally bad diet, but somebody, I just think about my parents who were both overweight, but they ate what they would have seen as a very traditional British diet. They had like meat and two veg, and it had your carbohydrates, it had your protein.
That's absolutely right. But it's what people, one, eat in between, two, drink. Because one of the things that I think people forget is that drinks, you know, all the coffees and lattes and cappuccinos, fizzy drinks, you know, orange squash, orange juice, all of those drinks are quite high in calories and sugar. I've worked with so many people whose diet itself, whose the food that they eat seems great, but actually it's all the other bits and pieces in between that are the problem. Snacks, and also too large a portion of things. It's very difficult to shrink your portion when you used to eat in large amounts. So it's quite a hard one, that one, because so many people believe they're eating a healthy diet. And when you break it down and look at what they're actually eating, if they're obese, the chances are they're not eating a healthy diet. That's the reality of it.
Yeah, and I suppose the GP, they've got to be willing to discuss it, and then the GP or nurse or whoever, they could help them look at their diet in more detail and go look at what is it that's driving the obesity.
Yeah, and I think it's not just food that affects your weight. And I think we need to remember that, like lack of sleep. If you're just getting 4 hours a night, you're likely to be bigger. Your weight's likely to go up. Stress, poor relationships in the family. You know, I don't know, you might be looking after someone who needs a lot of care, like you might be a carer for either a child or an elderly parent. The type of work we do. I mean, I've worked with truck drivers on the motorway networks. Their life's incredibly difficult. They leave home on a Monday, sometimes don't get back till Friday. They're sleeping in the van. They're having to stop every 2 hours. They'll often have a big latte or a fizzy drink to keep them awake. And their food that they have access to probably isn't great. They don't have regular meals. There's lots of other things that you probably need to discuss with someone who comes into your surgery and has got a weight problem, because there's often lots of other things that are causing it apart from eating. Obviously, eating is the main thing, but why are they eating? When do they eat? Why are they eating the kind of foods they eat? So those are the kind of things I think that we need to think about, not just the food that they eat. If someone isn't ready to believe that they're overeating or overindulging, or they're eating too much ice cream or eating too much chocolate, if they're not ready to believe that, then you'll never get them to do it.
I suppose it's like somebody who's got an alcohol problem or any sort of issue, they've got to be ready to address it themselves.
They absolutely have to address it themselves. And we can bring up the subject because obviously, as a healthcare professional who works in public health, it's my duty of care to give them all the information they require to change their health and make it better. But at the end of the day, it's their duty of care. It's the patient's duty of care to want to take it on board.
As a recap, which patients are currently eligible for weight loss medications on the NHS?
There's 3 or 4 different products out there. Semaglutide are originally developed for people with type 2 diabetes. So you could be offered these if you had a BMI of 35 or above, with 4 or more comorbidities, people who are of Asian origin, Chinese, Middle Eastern, Black and African or Afro-Caribbean. They would be offered it at a lower body mass index. And of course, it depended on your specialist weight management clinic, because in some areas you might be given it with a BMI of 30 and 4 comorbidities. And this varies massively between England, Scotland, and Wales. So we've got different legislation. In some areas, it's a BMI over 40 because they haven't got the resources, the funding, and they're limiting it down to the people most in need. Obviously, with the newer GLP-1s for obesity on its own, regardless of whether you've got type 2 diabetes, again, you need a BMI of 35 or a BMI of 30 with other weight-related comorbidities, such as diabetes, heart disease, high blood pressure, high cholesterol, those kind of things. And so, again, in some areas, it's a BMI of 40 for those. Obviously, what's on the guidelines, what's on the NICE guidelines, doesn't necessarily translate to what your GP is going to do when you go and see him. And for some of those drugs, you can only get the weight loss drugs, the GLP-1s, from a specialist service and not from your GP.
It's like the higher strength semaglutide for one.
Exactly. Of course, we can buy these drugs on the internet. You can get them from pharmacists and chemists. There's some specialist chemists that deal with weight loss. Lots of people get them online. They send in false medical readings. They lie about how big they are. They lie about how much they've tried to lose weight themselves. But I would advise anybody listening to this, if you want to go on GLP-1s, please make sure you get your drugs from a reputable source, preferably from a medical professional.
I think the thing as well, like GPs, though, that the difficulty with them is that they've got no control of what the patients, I mean, they can say all of what you've just said to their patients, but they can't fundamentally stop them from doing something like that.
Of course they can't. And as I say, I think I'm a firm believer and always have been, we can give patients, people, the best advice to our knowledge that we know. But at the end of the day, the patient will make their own choices. However, when they make a choice that's bad for them and they end up in hospital, we can then say, hand on heart, well, we've told you the risks. You've gone against what we've said.
Yeah, I was just going to quick word about tirzepatide, because unlike semaglutide, well, the weight loss version of semaglutide anyway, tirzepatide can be prescribed in primary care, but that is part of the roll-up program at the moment, isn't it? So, we're in the first couple of years, it's you have to have a lot of full comorbidities.
Yes, it is. It's a 12-year rollout program. Not everybody who could go on it can go on it straight away on the NHS. So we're starting off with the highest obese patients with the highest comorbidities, and then we're working our way down.
And so you were sort of talking before about how the GLP-1 medications, the aim of them is to reduce appetite. But can this lead to inadequate nutrition because a person doesn't feel hungry and therefore then they're not eating much at all? Or
Oh, massively. Basically, what happens is that your body switches off from the food noise, as they call it. I've spoken to so many people on it. They literally don't feel hungry. So they kind of almost have to think about eating, and they have to think about having a meal, and they have to think about making sure they have all the nutrients they require. So quite often in the first few weeks, they literally fall out of love with food, and quite often alcohol as well. So it has this effect that stops you having any urges. If, for example, you love ice cream, cakes and chocolate, when your appetite reduces, rather than having a meal, something nutritional, like with protein and vegetables, you might well just go for a chocolate bar or a bag of crisps or a biscuit, because you feel fuller much quicker. It increases your satiety. So you have a couple of bites of something and you feel like you're full. Your brain gets told you don't need any more. This can obviously lead to massive deficiency in vitamins and minerals. But more than that, when people stop eating as much as they did and start losing weight very quickly, a lot of that can be muscle loss, not fat loss. Start off with muscle loss. And the more muscle you have, the more your food gets distributed more efficiently. Whereas the more fat you have, the less likely your food gets distributed efficiently. As the muscle mass depletes, then as soon as you start eating normally again, your body will store that food as fat rather than muscle. And of course, we need muscle for energy. It's important when you're on these drugs that you continue to eat enough protein to keep your muscle mass in place, and also to do physical activities that improve your muscle mass.
And I suppose that's how the GP or nurse can help somebody who's on these drugs. They sort of can help them work out what food they should be eating, and they can. And then sort of saying there with exercise. I mean, I'd imagine if someone's very overweight, exercise is very difficult. What tips could you encourage them to take a little bit of exercise that could help them build their tolerance of exercise out?
It's worth pointing out that physical activity itself doesn't help you lose weight particularly. It's all about food and nutrition. And I think GPs, nurses, healthcare professionals should encourage patients to keep a diary of some sort of what they're eating in a day, because you literally forget to eat. So I would say whether you use a written diary, whether you use your phone, whether you take a picture of everything you're about to eat so you can look at the end of the day and think what you've eaten, and really importantly what you drink. Plenty of water. You need to drink plenty of water, because the other thing that happens if people aren't having a satisfactory diet, which often happens when they go on GLP-1s, is they become constipated. They're not eating enough. They're eating the wrong foods. So yes, definitely healthcare professionals should advise patients to have breakfast, lunch and dinner, small portions, make sure they get all the nutrients and the protein, carbohydrates, all the things that they require for daily nutrients in their diet, even if it's smaller portions, and to keep tag of it. And there are a couple of websites, I think Weight Watchers, and there's a couple of others. I think the Department of Health has a website as well that you can go on when you're on GLP-1, and it advises you on what. MyFitnessPal is another one, and they've got a specific area on there for patients who are on GLP-1 to ensure that they eat enough nutrition in their diet, and it gives them ideas of what they can eat to make sure that they're not deficient in any nutrients and vitamins.
Okay, and I'm just sort of saying that lose your appetite. But like, I am an emotional eater. I eat when I'm bored, I eat when I'm fed up and I'm angry, blah, blah, blah. And what about if that's the type of eater you are, that people might not have a big old bar of chocolate, they're not actually hungry, but they want that sort of comfort? Because even though they're not hungry as much, will they still have that desire?
Not on GLP-1, they won't. They won't have the desire to eat. It's strange. I'm listening to what people tell me, people who I see on the drug tell me, they say they literally don't think about food at all. I wake up and the first thing I'm thinking about is, what am I going to have for breakfast? What am I going to have for tea? That is in my head the whole time. When you're on GLP-1s, because the ghrelin leptin, the way that works, it literally tells your body you don't need any more. You don't need any energy. You don't need any food. So you don't feel hungry.
Just sort of going back to what you're saying about exercise, because obviously it doesn't necessarily help with weight loss, but it's important for building muscle and all of that. And is it true that any sort of exercise is good? Because even if they can all they can do is walk down the road.
Regular exercise is not going to the gym, because people don't like going to the gym. If you're 30 stone, the last thing you want to do is go swimming. One of my customers said she burns up more energy getting a bathing costume on than she does actually in the pool, because the changing rooms are so tiny and, it's difficult. And so I think you need to be realistic about what exercise is. And for me, it's movement of any sort. So if you literally walk from your sofa to your kitchen, and that is all the exercise you do, make sure you do that twice a day rather than once a day. If you walk to the back door of your house because you find it difficult walking, try every day to walk a little bit further, walk down your garden path, and just walking, gardening, just doing household chores, throw a bit of vigour into them, and that burns up calories and is a form of exercise. Walking up and down stairs, great form of exercise. Don't try and only walk upstairs once in a day. Go up and downstairs as often as you want. If you leave your phone upstairs, great, go upstairs and get it, even if it takes quite a bit out of you. The more exercise you do, the more you your body gets to doing exercise, the better it is for you. And it obviously, as I say, doesn't help you particularly with weight loss, but it's fantastic for weight maintenance. And it's also really brilliant for mental health, for your heart health, for your joint health, all of those things. So it's not just about weight loss, it's good for lots of other things, exercise.
You were saying you can get muscle loss with the GLP-1s.
Yes.
So exercise could help with that.
Oh, definitely. There are certain exercises, strength exercises, like bands, these restraint bands that you pull up and down. Weights as well are particularly good. Things like push-ups and sit-ups, although those are not for the faint-hearted. Squats, is another one. But what I would say is there's so much fantastic stuff online now, and little exercise videos and things, examples of how you can build muscle, that, for the majority of people. And obviously, I realise that not everybody will have access to these, but the majority of people now will have access to a phone or the internet. Go online, put in 5-minute muscle increasing exercises, see what comes up and choose one that suits you, because everybody's got different levels of fitness and everybody's got different capacity to lift weights or to do the stretch bands. Definitely find exercises online that will increase your muscle mass and that suits you.
Going back to GLP-1s, we've talked about how they can lead to muscle loss and possibly malnutrition because people aren't eating properly. But like the gastrointestinal side effects are also quite well known. If they're severe, can they cause problems with nutrition as well?
The major side effects, or the most common side effects, are nausea, vomiting, diarrhea, abdominal discomfort, and decreased appetite, which is obviously what it's meant to do. And all of those things can cause you to not eat enough nutrients in the first few weeks. Most people say that those side effects disperse after 2 or 3 weeks. But of course, in those first 2 or 3 weeks, if you're used to eating a lot of food and then suddenly for 3 weeks you're hardly eating anything, you're going to have a massive weight loss very quickly. Your energy is going to be depleted very quickly. You might be lightheaded and feel dizzy because your body isn't used to that small amount of food. So going back to what I was saying earlier on, it's really important when you're on these drugs to make sure that you record and look at eating at least 3 small meals a day that include healthy options.
I was just going to say, this whole drive at the moment, we should all be, for various reasons, all be moving to a more plant-based diet. Aside from anything else, perhaps your diet has changed and you are perhaps eating a healthier diet. Can that take some getting used to, that these patients are perhaps now eating a healthier diet and they're having side effects from the body actually functioning a bit more better?
Oh, yes. Maybe someone's used to going to the toilet once a week, and then suddenly if they're eating lots of vegetables, they're going every day, especially if they're drinking more fluid. Again, I'd like to reiterate the importance of drinking fluid, because that obviously helps your body function. Our bodies are made up of 70% water, and we definitely need lots of water in our body. It takes a long time for people to change the way they enjoy food. And I think it should be one step at a time mentality. So don't try and change it all at once. Try and get used to eating a different diet slowly. Don't try and do it all at once. And there are so many great recipes now. And when you're on GLP-1, it's an ideal time to start thinking about what you actually put in your body and what you eat.
That's how a healthcare professional can help. They can advise them. If your diet gets healthier, this might happen. This is
definitely. I think it's important for a healthcare professional who's dealing with someone on GLP-1 to sit down with the patient. It's very hard because we're all time poor, aren't we? Especially in the medical profession. And I would say that when I worked in my practice, and if I was going to advise any practice, I would say have a healthcare professional who deals solely with or has an interest in obesity management, who can sit with a patient, especially for the first time, for at least half an hour, to go through with that patient the kind of diet they should be having, the kind of foods they should be avoiding, the kind of foods they should be encouraging in their diet, and the reasons why they should change.
Okay, and so, because if they're on the GLP-1s, they've been given all this advice and all of this, the side effects are tolerable. After 6 months, if they haven't lost,
if they haven't lost 5% of their body weight, they have to come off it.
So, they've gone for their review. How can a healthcare professional help them sort of stay on the drugs and help them lose that weight that they don't appear to be losing?
Right, well, this is going to sound really harsh because having worked in this area for the last 25 years, I think you do have to be harsh. It's not the healthcare professional's duty to do anything apart from give the patient the tools they need to change the way they live their life. And if after 6 months someone comes into my clinic and says, oh, it hasn't really worked, what hasn't worked is they haven't worked. That hasn't worked. They haven't really taken it as seriously as they should. Again, they will have. Anyone who goes on GLP-1 will probably have gone on every single diet that's going in. They've all tried lots and lots of diets. They all know what they should be eating and what they shouldn't be eating. These people aren't suddenly completely free of any thoughts about what's good and what's bad. They have gone through probably a lifetime of looking at good nutrition and things like that. So I think as a healthcare professional, all you can do is sit with them and try and explain that they have to be committed to this. They have to be committed themselves. Years and years of this, people come and see me and they go, oh, you were on holiday last week and now I've put on weight because you weren't there. We have to make patients believe that it's their responsibility and not ours. We're not the drivers of this. All we're doing is giving them information. Of course, we can be supportive. We can tell them they're doing a great job, or we can say, you're doing a terrible job. We can be supportive, but we can't do it for them.
Going to the British Obesity Society, what resources do you have that healthcare professionals could share with patients?
We have very few resources. We have 2 leaflets that we've produced, one for men and one for women. For any GP practice that asks for them, we'll send them a pack out. Apart from that, we tend to go to various organisations, charitable organisations and organisations around the country and do talks to people, because we feel that the face-to-face conversation is a much better way of giving people information and finding out what it is they want to know. Because when people get leaflets, they very rarely read them. People come in, we give them a load of leaflets, and I'll quiz them the next time they come in. So what did you think of page 3? And they look at me blankly because they suddenly realise that they haven't even looked at them. They've put them on the side. It's the same with books and everything else. I think something like a podcast, something audible where people listen to that information, I think it's much more powerful. And so for us, we're a lobbying organisation. We work closely with the Department of Health and government bodies to try and change legislation. We've sat on NICE boards to look at potential drugs for obesity. The key is there is so much information out there. The NHS websites, I don't know whether you've been on there and looked at the obesity section there, but it's great. We believe in why reinvent the wheel. There's so much good information out there on legitimate sites like the NHS website that there's no point in us all saying the same thing.
And what are your 3 take-home points for healthcare professionals about supporting people with obesity?
This is really difficult for me because I've got more than 3. First, bulk cook and freeze so you've got food already cooked, so it feels like you've got like a ready meal. Drink plenty of water. And avoid buying snacks that you're going to eat. So don't have them in the house. Avoid fizzy drinks and other high-calorie drinks. Absolutely crucial. So many people take their calories from alcohol, fizzy drinks and high-calorie drinks during the day. Try and get 8 hours sleep a night. I know it's really difficult. Try and take a few minutes a day, and this is a hard one. Nobody ever thinks of this, where you completely clear your mind, take some deep breaths, and try and get rid of all the tension and anxiety, because when you've already mentioned it earlier on, when you are anxious and stressed, you tend to eat more. So try and de-stress. If you feel you're in a stressful situation, take yourself out of it, sit down for 5 minutes, try and relax, take some deep breaths and think, be active. Try and be active every single day, even if it's just a little bit more than you did the day before. And I think finally, we only have one body in our life, and it's not like a car. We can't change it every 5 years or get it serviced or MOT'd. If it starts going wrong, that's it. We need to realise that we need to look after our health, because it is the most important, precious asset that we own. It's more important than anything else that you own in your life, your body. So look after it. And finally, try and remember just one step at a time. You don't have to do everything all at once. You don't have to change your diet all at once. Maybe drink more water for a week and then go on to reducing the amount you put on your plate, and then go on to reducing buying chocolate and crisps and things that you know aren't great for you. And gradually over time, this will have a massive impact on your body.
Okay, so I suppose that's things that healthcare professionals can pass on to patients, and also perhaps healthcare professionals can sort of consider themselves.
Lots of healthcare professionals don't look after themselves. I do trainings for doctors and nurses. A lot of doctors and nurses have an issue with understanding what a healthy diet is, also how to achieve it, because of shift work and working late and families and other commitments. This is for everybody.
Thank you for joining me today, Jane, and thank you to our listeners for joining us. Don't forget, you can claim CPD credits for listening to these podcasts, and there are plenty more on the MIMS Learning website. I've been Dawn Liz Powell, speaking to Jane DeVille-Almond from the British Obesity Society. This episode was produced by Jude Owen.